So hello everyone, welcome to my new video. So today I will discuss with you all about keratoconus. Okay, so let's start. So before starting the presentation, let me tell you about the objective of today's class. So after completion of this presentation, you will have the idea about the grades of keratoconus. Then you will have the detailed knowledge about the clinical features of keratoconus. Then you will have the detailed knowledge about the investigations that we send for the keratoconus patient, and also you will get to know about the management strategies for keratoconus. Okay, so here in this slide you can see two eyes. Okay, right? So here, what is the main difference between these two eyes? So here if you see the cornea, so here the cornea is looking very normal. Okay, but here it is not looking normal. If I tell you in the corneal curvature aspect, then this cornea is having normal corneal curvature, but it is not having normal corneal curvature. It is looking in a conical manner. So this is keratoconus that we are going to discuss today. Okay, so keratoconus is a non-inflammatory corneal ectatic disorder where cornea become unable to hold its shape properly, so it bulge out like a cone. That is keratoconus. Okay, so let's go to the etiology of keratoconus. So in a research published in 2015 in Saudi Arabia, they found that people who in an age range between 20 to 40 are more prone to have keratoconus than people having after 40s. So 20 to 40, this age range is quite risk factor having developing keratoconus, right? Then if someone is having developmental abnormalities like Down syndrome, then he can also develop keratoconus. If someone is having eye rubbing tendency, excessive eye rubbing, so due to the excessive eye rubbing, it lead to damage to the corneal stromal fibers. There is collagen fiber. So because of the stromal collagen fiber damage, it lead to corneal weakening. So that is why cornea become unable to hold its shape properly and it bulge out like a cone. So that means it can lead to keratoconus in the later life, right? If someone is having a rubbing tendency, eye rubbing tendency. If someone is having family history of keratoconus, suppose the patient grandfather is having keratoconus, then his offsprings can also develop keratoconus. So because keratoconus can be flow in a heredity manner, so that's why if someone is having keratoconus, then his offspring should also undergo a routine eye examination to detect any type of corneal ectatic disorder. Okay, or if someone is having diagnosed vernal keratoconjunctivitis. So this VKC is a hypersensitivity reaction in the eye. So because of this VKC, the patient may develop giant cobblestone papillae on the UTC as well as Horner-Trentas dot and roughness of the epithelium. So because of the giant cobblestone papillae on the upper tarsal conjunctiva, the patient develop lots of eye rubbing tendency. So that is leading to corneal mechanical injury to the cornea because of the excessive eye rubbing. So this is why it can also lead to keratoconus in the later life or in very future. Okay, so let's discuss about the clinical finding of keratoconus patient. So here the patient came to you. If he is not having any complaint or difficulty, then he will not come to you, right? But he is having some abnormality, that's why he came to you, right? So if the patient come to you and saying that I am having glasses or contact lenses, but still the vision is not that much clear, I am not satisfied with the vision, then you may suspect something abnormality is going on and you should examine properly to that patient. Normally the patient come for refractive surgery when they have they need for any requirement of military, or they are having any marriage. But if you find a patient came to you uh, just because he is having glasses or contact lenses, but he is not satisfied with the glasses, so that's why he came for refractive surgery to improve his vision, then you may suspect maybe some corneal ectatic condition can also be there. So that's why examine it properly to look for those signs that is telling you that yes, person may have keratoconus. Then if patient say that his vision getting improved when he press his eyes, then also it can be an uh, hint to you that whenever he press his eyes, then the corneal irregularity get smooth and can be recovered, so that the vision get improved because of the pressing, some kind of corneal irregularity getting normal. So it is also an alarming sign that person may have some abnormality in the cornea. So that's why he is giving complaint like that. Okay, or if the patient say that, hey, my grandfather having keratoconus, so that's why I came here for routine eye examination, then you may suspect the person may have keratoconus. What are those symptoms that patient can say? Patient can tell you that distortions of images. Now patient can also say photophobia, difficulty in night driving, or sudden blurring of vision if the person have keratoconus. Now these are the types of keratoconus. There is 4 types of keratoconus. First is round or nipple cone keratoconus, then shagging cone keratoconus, former foster keratoconus, and keratoglobus. Starting from round and nipple cone keratoconus. So here in this type of keratoconus, the affected area is very much small. That means the affected area is less than 5 mm area is affected, and mostly in this type of keratoconus patient, it is seen that central portion is affected, or inferonasally the cone is quite displaced and the localized area is quite small, less than 5 mm area, but the affected area becomes severely affected. It is having very severe steepening or very severe thinning. So this type of round or nipple cone keratoconus is quite severe manner. It happened in a quite severe manner. But if I tell you about the shagging or oval cone keratoconus, then here the affected area is quite larger than the nipple cone keratoconus. And here the shagging cone or oval cone keratoconus, here this cone quite displaced in the peripheral part or inferotemporal part. Here you will see a big area is involved here. Let's talk about the form of keratoconus. Here I put a picture of suspect. He is a suspect. That means there is no clinical sign of keratoconus. There is no monsoon sign, rigidity sign, Fleischer ring, nothing is there. But when the patient underwent tomography, that is pentachem, then you find some values that are abnormal. So this is how you will get to diagnose that yes, the person may have keratoconus in the future, but now he is not having keratoconus. So what he is having, he is former poster keratoconus. That means you are suspecting that the person have keratoconus, but now he is in present he is not having keratoconus. If I tell you about the keratoglobus, that means the entire cornea is involved in keratoglobus. So here entire cornea is involved, right? Now in this picture or in this slide you can see a pentachem report. Here let me read the report for you. Here first of all what we need to see, we need to see the QS value, it's okay, Q value is also normal. The KMX value 43.8 and thinness local 559, it's normal, right? If I tell you about the sagittal map, then here you will see asymmetrical bow tie with superior steepening is there, but the difference between these two is in normal range, right? Here also, if you see the central thinness corresponding point in the thinness local is 6, it is normal, but here this point is quite suspected. There is plus 11. It should be less than plus minus 12, but it is plus 11, so it is in borderline, right? If I tell you about this, then here also you can say, because here central portion area, here point is less than plus minus 12, and here this is quite suspected, plus 17, and here minus 16. So this central 3 mm area zone point, this point should be less than plus minus 18, but it is in borderline. And if you see this is plus 17, this is minus 16, so difference is there in borderline, but then also it's quite suspected. Then if you see this corneal thickness map, so here if you see the corresponding point, here 629 and here 582, and difference is more than 30, that is indicating yes, something abnormal is there. Now you will see most of the values are within normal limit, then also some values are abnormal. So this is a case, this can be a case of form of keratoconus. So here for this purpose we need to say Bellin Ambrosio enhanced ectasia map, where this is the elevation front and this is the elevation back, and after applying the enhanced best fit sphere when the difference is calculated, then we can see that yellow spot is there. That is indicating something abnormal is going on and it is suspected. So this is a case of form of keratoconus. Okay, so this is how you will diagnose that there is no clinical sign, nothing is there, there is no seizure reflex, there is no apical scarring, there is no prominent nerve ending, but when you send the patient for pentachem, you will find some values are abnormal. So this is how you will diagnose case of form of keratoconus. Now let's go to the grades of keratoconus. So grades done by Amsler-Crummage classification, where there is 4 grades or 4 stages of keratoconus. Stage 1, stage 2, stage 3, stage 4. So the stages of keratoconus segregated based on what is the amount of myopia and astigmatism, what is the value of Kmax, and also what is the corneal thickness. So in stage 1 it is quite minimal. So here you will see myopia and astigmatism less than 5 diopter and average Kmax value less than 48. So in pentachem the Kmax value borderline is 47.20. Okay, if it is more than that, then we suspect the person may have something abnormalities going on. So here if it is 48, yeah, 49, you can say yes, it is in stage 1 if the corneal thickness is in normal range, but the Kmax value is quite more than 47.20, then it is quite suspected. Then if I tell you about the stage 2, here myopia and astigmatism, myopia more than 5, astigmatism more than 8 diopter. Whenever you are doing refraction to the patient, if you find very high amount of cylindrical number is there, do prefer to send the patient for scan and pentachem to rule out any chance that the patient may have keratoconus and you misdiagnosis as refractive error. So that's why don't take any chance. If you find something abnormal value or higher cylindrical value like more than 5, 6 diopter, then do send the patient for pentachem or scan. Okay. In stage 2, more than 5 diopter of myopia and more than 8 diopter or less than 8 diopter of astigmatism is there, as well as Kmax value less than 53 but more than 48 and corneal thickness more than 400 but less than 500. That is stage 2. In stage 3, myopia more than 5 and astigmatism then less than 10 or 10 but more than 8, then it is grade 3 or stage 3. Now in stage 3 you will see Kmax value more than 53 and you will not see any corneal scar but central corneal thickness in between 300 to 400 micrometer. Now in stage 4, here you can't do refraction to the patient and you will see average Kmax value more than 55 diopter. In many patients we see Kmax value more than 60 or more than 70. Corneal scar is there as well as perforation is there because of the acute hydrops, and then corneal thickness is 200 micrometer. Okay, so let's go to the clinical features of keratoconus. What are those things that you will see in a keratoconus patient? So let's start. So this is the monsoon sign. So here what I told you that there is conical protrusion of the cornea because the cornea is not able to hold its shape properly, so that's why it's bulged out like a cone. So if you are suspecting that the patient is having keratoconus, then instruct the patient to look down and pull the upper lid. And if he is having keratoconus, that is conical protrusion of the cornea, then the conical protrusion area will indent the lower lid. So it will appear in a V-shaped manner. So that is indicating that yes, this is the presence of monsoon sign. So the patient may have keratoconus, and you try to look for other signs like presence of Fleischer ring. So Fleischer rings are the iron deposition on the base of the cornea. So this is Fleischer ring. Okay. So this iron come from the tear film. Okay. So here Watt striae, because of the conical protrusion, it lead to folds in decimate membrane, that is leading to vertical fold, and it is ultimately leading to Watt striae. Now I will tell you that there is two types of striae that we see. One is Watt striae, another is Hab striae. So you will see Hab striae in case of ophthalmos patient, where you will see horizontal lines, but in case of keratoconus patient you will see vertical lines. So these lines actually rely on decimate membrane level. So here the folds of decimate membrane is there because of the conical protrusion, that is Watt striae. Now rhizoticine, if you shine the torchlight from the temporal side, then you will see the shade of the cone is falling on the nasal side. So this conical shade is called rhizoticine. Okay. Acute hydrops, because of the conical protrusion of the cornea, it lead to break in the corneal endothelium as well as decimate membrane, so that the endothelium pump mechanism failed and aqueous humor get inside the corneal stroma, leading to stromal edema. So if the patient have acute hydrops, he will give you complaints of eye pain, photophobia, glare, and blurring of vision. Okay. So here prominent nerve endings. So these are the very much important finding that we see in case of keratoconus patient. So how you will see this prominent nerve ending? So I will tell you that make sure you are making parallel pipe and make the highest illumination highest magnification present in your slit lamp. Like most of the slit lamp having highest magnification 40x. To put your slit lamp in 40x, use the parallel pipe. Angle should be 30 to 45, and then see the cornea. Then if he is having keratoconus, then try to look for this prominent knob ending. Here you will see white thread like structures are there. These are knob endings in keratoconus patient. Now, apical scarring. Why apical scarring? Because of the conical protrusion of the cornea, it lead to Bowman membrane involvement or Bowman membrane damage. So because of the Bowman membrane damage, it lead to scarring formation, because corneal epithelium can regenerate, but once Bowman membrane disrupt, it can't regenerate. So it is leading to apical scarring in the Bowman membrane area. Okay. Now, whenever you are doing refraction to the patient by retinoscopy, you will see Caesar reflex. So you can't neutralize completely a Caesar reflex. So that's why whenever you are getting Caesar reflex, then try to focus in only one meridian. Don't try to neutralize both. You just need to focus one and stick on it. And when this reflex will get a single reflex, don't try to neutralize these two at a time. Try to neutralize this single one and make it quite border manner. If this also not work, then you can send the patient for a scan to see what is the axis, and according to that you can proceed to the refraction and subjective acceptance of the patient. Okay. Now let's read this pentacam report. So it is a case of keratoconus where you can see QS value within normal limit, but Q value is more than plus minus 0.85. It is abnormal. Then the Kmax value is 76.7. That is abnormal. There is more than 55. So it is in what to say grade 4 or stage 4, right? Then thinness local is 335. Now if you see here in the sagittal curvature map, it is a round or nipple cone type keratoconus. Here you will see localized central area is affected, where this is a symmetrical bow tie pattern is there. Here if you see the difference between these two, it is more than 2. That is indicating abnormal is going on in the cornea. Then if you see this elevation front map, then the corresponding point of the thinness local is 39, where it should be less than plus minus 8, and here central 3 mm area points are more than plus minus 12. It is 55 and 29, so it is abnormal. So these values are indicating that something abnormal is going on in the cornea. If you see the elevation back, in elevation back also the corresponding point of the thinness local is 94, and central 3 mm area here you can see plus 78, that is more than plus minus what to say 18, so it is also abnormal value. If you see this corneal thickness map, so here you can see this is 378, this is 558, that is more than 330 micrometer. That is also quite abnormal. That is indicating something ectatic condition is going on in the cornea. So if you look at the Bellin-Ambrosio corneal ectatic map, so here you can see that it is expressed as red color. That is indicating yes, there is a presence of keratoconus. And then you need to see the average value. It is more than 1.20, that is abnormal, and the red line is getting deviated before 2, so it is indicating yes, the patient is having keratoconus. Now if you see this case here, QS value within normal limit, Q value will also within normal limit, Kmax value within normal limit, thinness local 588, that is also within normal limit. If you see this sagittal map, then it is symmetrical bow tie pattern, and the difference between the corresponding point here in this point, these are less than 2, that is absolutely normal. Here if you see that the elevation front, then the corresponding point of the thinness local is plus 8, that is within normal limit. But if you see here, this is more than plus minus 12, that is abnormal value here. And if you see in elevation back, then you will see this point it is in borderline, where it should be less than plus minus 12, here 11, and here central 3 mm area zone points are plus 24, that is more than plus minus 18, so there is a abnormal value. If you see here, then you can look at this point here 640 and 606, that is more than 30, that is indicating quite abnormality is going on in the cornea. but rest values are normal, so it can be a case of form of osteokeratoconus. So let's see the Velin-Ambrosio map. So here you can see there is yellow color is indicating that yes, it is quite suspected cornea and the patient may develop keratoconus in the later life, but now onwards he is not having that much higher risk of or higher type of keratoconus diagnosis. So that's why you can diagnose the patient having what to say form of osteokeratoconus. As the red line is also continuous up to 6 mm area and average value is 0.89, that is less than 1.20. So this is the case of form of osteokeratoconus. But if you see this case here, QS value is okay, but Q value is beyond normal limit. Then if you see KMX value 64.5, that is more than 55, and also thickness local is 445. The normal corneal thickness is 540, right? 530 to 540, but it is 445, it is less. If you see the sagittal map, here you can see this portion is getting steepened, okay, then this portion. And if you measure the difference between these two corresponding point, then it is 51 and it is 56, more than 2, that is abnormal. Then the corresponding point of the thickness local is 41, that is abnormal value. And here central 3 mm area zone points are more than plus minus 8, so it is also abnormal. Now if you see this elevation back, then corresponding point of the thickness local is 73, that is more than plus minus 12, and central 3 mm area zone point are more than plus minus 18, so it is also abnormal value. Now if you see here, it is 487, here 548, that is more than 30, that is indicating abnormal value. So it can be a case of keratoconus. So here if you see here, in case of by using the enhanced best fit sphere, it is indicating in red color, that is indicating yes, the person is having keratoconus, because the red line is also getting deviate before 2 and the average value is more than 1.20, so that is why the person have keratoconus. Now here different shapes that we see in case of sagittal map. So here I want to tell you again, here the round, this is oval, superior steepening, inferior steepening, irregular, that you see if the patient have corneal scar and you send the patient for what to say pentacam, then you will see irregular pattern. This is a symmetrical bow tie. This symmetrical bow tie with skewed radial axis, asymmetrical bow tie with inferior steepening, asymmetrical bow tie with superior steepening, asymmetrical bow tie with inferior steepening and skewed radial axis. These are the butterfly, clap claw and vertical. These things can be seen in PMCD cases. So if you are suspecting that the person is having keratoconus, then you need to send the patient for pentacam. So pentacam is the tomography. Okay. So here because pentacam is based on Semplak imaging, so it can examine the corneal every layer properly. And one thing that you also know, that keratoconus always start from the posterior to anterior. Okay, it never start from anterior. It start from posterior because of the arrangement of collagen fibers of the stoma. Like anterior is more arranged, but posterior is less arranged. In peripheral there is more collagen fibers are there than the central. So that's why it start from posterior and move towards anterior side. Then you also need to send the patient for a scan for the measurement of corneal curvature, right? If you are planning for contact lens trial to the patient also. Now you also need to send the patient, or you can send the patient for anterior segment optical coherence tomography to examine properly about the protrusion of the eye. So here one thing that I want to tell you, that in keratoconus, when the eye is protruding outward by making the what is a conical shape, so it is leading to axial elongation. So this is how it is leading to myopia. There is a pathological myopia, as well as due to the irregular corneal curvature, it is leading to irregular astigmatism. So regular astigmatism means the difference between two meridian power is 90 degree. But in case of irregular astigmatism, it is not 90 degree. It is less than 90 or more than, but it is not 90 degree. Okay. Now let's go to the management. How to manage a patient? You diagnose the patient having keratoconus, you send it for investigations, investigation done, everything done. Now you have to give some management to the keratoconus patient, right? So that's why the first management that we can give to the patient is spectacles. Give spectacle correction to the patient. Try spectacle first. If it is not done, then you can go for contact lenses. But before, try spectacle and try to give best corrected visual acuity, because spectacles are quite cheap, patient can afford it also. So that's why try with spectacles, and if the vision is not improving that much, then go for contact lenses. There is various types of contact lens that can be used for keratoconus, like especially for keratoconus, rose gate contact lenses are used, apart from that, scleral contact lenses can also work very nicely in case of keratoconus patient. Okay, so in case of stage 1 and 2, you can give spectacle correction to the patient if the vision improve, and if vision not improve, then you can go for contact lenses up to stage 3. But stage 4 and 5, then the patient not get that much good vision with contact lenses, but most patient also get improved visual acuity by scleral lenses, large diameter scleral lenses, even in case of stage 3 or 4 keratoconus. Okay, now you can also send the decide for collagen cross linking. So if you are seeing that the patient corneal thickness is within 400 micrometer, and there is a variation of corneal, there is a reduction of corneal thickness. Suppose now the patient came and here you found one corneal thickness, central corneal thickness, and in the 6-month follow-up visit, if you observe there is 10 to 20 micrometer of difference between these two follow-up visit, then you can think that you should go for collagen cross-linking. So this collagen cross-linking is a very minimal invasive procedure that is used to prevent the keratoconus progression or post-LASIK ectasia. So here 3 components are mainly used. First of all, ultraviolet radiation, second photosensitizer, and third is the photochemical reaction. So here the photosensitizer actually is work to absorb the light energy, and it produces some chemical changes to the underlying molecules. So here the photosensitizer is riboflavin or vitamin B2. Okay, so here riboflavin absorb UV light rays of 370 nanometer. So here UV ray that is used is UVA. So there is 4 type of UV light rays are there: UVA, UVB, UVC, and UV. So there is 3 types of UV light: UVA, B, C. Okay. So here UVA wavelength is 315 to 400 nanometer. UVB it's having wavelength of 280 to 315 nanometer, and UVC having wavelength of 100 to 280 nanometer. But for our eye, UVA is quite not that much harmful, or as well as it is good for collagen cross linking, that not lead to that much damage to the underlying structures. So that's why UVA is mostly used. And once exposed to UVA, the riboflavin generate reactive oxygen species which that help the formation of covalent bond between the collagen molecule. So that's why riboflavin is very much helpful in collagen cross-linking to give cornea strengthening. Okay, now if you see that the corneal thickness is in between 350 or 400, vision is not improving with the contact lenses also, then you can plan for intrastromal corneal ring segment. So here this intrastromal corneal ring segment help to minimize the corneal steepness. Okay, so that it will reduce the amount of astigmatism, and it can also improve the vision. So after giving intrastromal corneal ring segment, you can place the contact lenses over it, and the patient can get a very good visual acuity. Remember one thing, that if you are giving glasses or contact lenses, it is just improving the vision, but it is not helping to stop the progression. And to stop the progression, you can prefer collagen cross-linking. Okay. Now, if nothing was working and the progression is very much higher manner, and the corneal thickness is 200 or less than that, you have only one option, that is keratoplasty. Now in keratoplasty, if you observe that decimate membrane and endothelium is healthy, then you can leave them in the eye, and apart from decimate membrane and endothelium, you can plan for dissect. If everything is involved, formation of acute hydrops, perforation is there, full thickness corneal transplantation is there, where surgeon prefer optical penetrating keratoplasty. Okay. So that's all friends. Thanks for watching, and please don't forget to like my video, subscribe to my channel. I hope this video helped you to understand about keratoconus more, and if you have any question, then do prefer to put it in the comment section. Thank you so much.